Hi, good evening. Is the voice clear? Video, audio, all clear, all good? All good. Should we start? Okay, so have you attended the questions? The questions are easy. Now, anybody got like all 25 correct? Let's see, let's discuss. Anna, good evening, Saf, Vasantha, Ankita, Megha, Rashri, Anjesh. Okay, so let's see. Mohit, Sunil, good evening. Okay, hope you are reading well and you are practicing MCQs also. Okay, now the exam is in like less than 1 month, around 1 month, so don't lose focus. Okay, this is the last 1 month. You should give your best, your everything. Video is little blur. Video is fine. Okay, the screen should be fine. Okay, the video is okay if it is blurred. Okay, so let's see the first question. Which among the following does not form Calet's triangle boundary? Calet's triangle boundary. Now I want you to comment and I'll just tell what is Calet's triangle. Okay, so this inferior surface of the liver. This is the common hepatic duct and the cystic duct. These are the boundaries. Yes, these. Why you are saying inferior surface of liver? That is, see, in the class also I told you that don't get confused. Don't see if somebody else is giving some different explanation. This is given in Bailey and Love. This is given in Blumgart. It is like the Bible of hepatobiliary surgery. So don't do any mistake. Okay, cystic artery is the content. Okay, so this whole thing is the triangle. This is the triangle. So these are the boundaries of triangle: inferior surface, common hepatic duct and cystic duct. And cystic artery, which is running inside it, is the content. Okay, you can say cystic artery is the content. Okay, cystic artery is the content. Okay, so please, these are easy questions. Don't do any mistake. Question is wrong. How come question? Which of the following does not form Calet's triangle boundary? So Calet's triangle boundary is cystic duct, common hepatic duct, and inferior surface of liver. Cystic artery does not form a boundary. Cystic artery is the content. Okay, so question is not wrong, Prachi Pandey. Okay, no confusion, no nothing. Okay, all clear? Yes, going to the next. Okay, Prachi, is it clear? The question is not wrong. It is just that artery is the content, not the boundary. Okay, next question. Question number 2. Identify the maneuver being performed in this picture. So can you see in this picture? What is cattle brush maneuver? What is mattocks? What is cockers? What is Pringles? Let's start with Pringles. Pringles is when you see this is the hepatoduodenal ligament, in which there is portal vein, hepatic artery and bile duct. So if you compress this thing, the hepatoduodenal ligament, okay, this is hepatoduodenal ligament. It is going between liver and duodenum. So if you compress this, that is Pringles maneuver. Okay, this we do for the liver bleeding and liver injuries. We do this. Hepatocystic triangle was multi-star. It was previously, like in all the books now it is written that previously people were saying that this is Callett's triangle, and that which we are saying now as Callett's, the people they say it is hepatocystic triangle. But believe me, if somebody else or some other platform is saying that hepatocystic and Callett's are different, it is same these days. Hepatocystic triangle and Callett's triangle is same. There is no difference. Previously this confusion was there. So that's why you should remember only one triangle. You can call it as hepatocystic, you can call it as Callett's. It's not different. Okay, so this is Springer's maneuver. Cocker's maneuver is when you do mobilization of the duodenum. Duodenum mobilization, because duodenum is also a fixed structure. So when you mobilize the duodenum for any like pancreatic surgeries and all, we do Cocker's maneuver. Okay, Kettle-Brashe's C. Suppose this is the large intestine and this is abdomen. So this right colon, it is fixed to this lateral abdominal wall, and the left colon, it is also fixed, descending colon. So when you do mobilization of this, you will mobilize this and push this part towards the midline, so that you can see on this side, you can see the IVC, you can see the right kidney. Okay, so this is known as right medial visceral rotation, known as Kettle-Brashe maneuver. So this is Kettle-Brashe, right visceral medial rotation. And on the other side, if you do the mobilization of this and move this left or the descending colon towards the midline to see the aorta and the left kidney, that is left medial visceral rotation or Mattox. Okay, so this is difference between Kettle-Brashe and Mattox. Kettle-Brashe is to see the right-sided, retroperitoneal structure, and Mattox is done to see the left-sided retroperitoneal structures. You can see in this left side is being seen. This is the left side. Okay, so that part is mobilized. You can see aorta nicely. This is a Mattox maneuver. This is a Mattox. You can see here also the whole left side is shifted towards the other side, towards the midline, so that you can see the aorta, so that you can see the left kidney. Okay, so this is left medial visceral rotation or Mattox maneuver. Okay, Mattox is left side and Kettle-Brashe is right side. Okay, you can make any mnemonic that the Kettles, they move towards the right side. The Kettles, they always move right. So like that you can say something. Okay, you can remember it like that. Kettles, they always move right. Okay, so Kettle-Brashe is for the right sided and Mattox is for left side. Okay, so I mean you can make your own mnemonic. This is also I'm saying for the first time, the Kettles always move right. So something you can come across and you can remember it by your own way. Yes, you can say like that, gallbladder, Kettle-Brashe. Okay, whatever you find suitable, you can make this. Okay, so this is Mattox maneuver. Any confusion, you just let me know in any question if there is any confusion, any controversy, so that I can keep on clearing. All these things you have already read. Okay, so nothing is new in this. So just trying to brush your knowledge. Identify the technique of breast assessment shown in the image. What is this method of assessment where you are going like this, then this, then this? What is this method? Wedge method, vertical stripes method, dial clock method, or circular method? Yes, very good. Vertical stripe method. This is vertical stripe method. Circular method or circumferential is when you suppose this is the breast. When you do the percussion like this, I mean when you do the palpation like this. Okay, so that is circumferential or circular method. Circumferential or circular method is this. Dial clock method is, you just imagine this as a clock, 12 o'clock, 6, 3, 9 o'clock, like this, and whatever, 1, 2. So you can divide the breast into like these clock position, and then you have to palpate. You can come from periphery to the center, or you can go from center to the periphery. So make sure that you don't miss any area. So that is dial clock method. Wedge method is the one in which you divide the breast into quadrants, 4 quadrants, and then you palpate one quadrant at one time. Okay, so that is wedge method. So wedge method, vertical stripes method, dial clock method, and circumferential or circular method. This is vertical stripes method. Okay, this is a vertical stripe method. Okay. Next question. Read the question and tell me the answer. Okay, take your time, take 1 minute. 40-year-old lady, 3 by 2 centimeter breast carcinoma in the left breast. Lump is attached to the pectoralis major muscle, and there are fixed and matted axillary lymph node in the left axilla and mobile axillary lymph node in the right axilla, which also shows the presence of tumor. What is the stage? Tell me, what should I write in T, N, and M? What should I write? It is 3 by 2 centimeter. So it will be T2. Now if you remember, T1 is 2 or less than 2 centimeter. T2 is more than 2 to 5 centimeter. T3 is more than 5 centimeter. T4A is chest wall involvement. That does not include pectoralis. Okay, chest wall involvement means ribs, intercostal muscles, and serratus anterior. T4B is skin involvement. That means there is satellite nodule, ulceration, or podiorange appearance. Retraction of the nipple and dimpling is not included. T4C is both chest wall and skin involvement, and D is inflammatory carcinoma. Okay, so this is the T staging. N staging, yes, N0 is no lymph node, N1 is ipsilateral mobile axillary lymph node, N2A is ipsilateral fixed axillary lymph node, B is ipsilateral internal memory without axillary, and 3A is ipsilateral infraclavicular or apical, B is ipsilateral internal memory with axillary, and C is ipsilateral supraclavicular. Okay, so everywhere you can see ipsilateral is there. If there is contralateral, like in this question, the carcinoma is on the left side, there is left axillary involvement as well as right. So if contralateral lymph node, it is same as M1. In T4B, there is pudiorange T4B, which, see, Prachi, suppose they say that there is a lump. There is a lump, and around the lump there is body orange. Then it will be T4B. Okay, suppose they say there is no lump and this body orange appearance is involving at least more than 33% or 1/3 of the skin of breast, then it is inflammatory carcinoma. Okay, so now you know, if the body orange appearance is associated with a lump, then it will be T4B. If there is no lump and this body orange is at least more than 33% or 1/3 of the skin of breast, it is inflammatory carcinoma. Okay, hope you can differentiate now by this, Prachi. Okay, so this question Yes, this thing says it is T2. Fixed and matted lymph node says it is N2A. And right axilla says it is M1. M1. Okay, so the answer here is D. T2, N2, M1. T2, N2, M1. Okay, any confusion? Any confusion? Any question? This is one of the most important TNM I told you. You need to remember this TNM. Okay, should we go to the next question? Pectoralis muscle is not chest wall. Okay, champ, chest wall, remember, no pectoralis or latissimus dorsi. No. No. Skin involvement, dimpling and nipple retraction is no. No. M1 Bhagya Lakshmi, because it is causing contralateral lymph node involvement. You can see the tumor is in left breast and there is right axilla is involved. Right axilla, lymph node in the right axilla. So that is contralateral lymph node. That's why it is M1. Okay, contralateral lymph node. That's why it is M1. Fine. Should I go to the next question? Okay. 26-year-old male presenting with thoracic trauma on right side with respiratory distress with hypotension. On auscultation, breath sounds were found to be diminished on the right side. Tell me the diagnosis first. Tell me the diagnosis. Tell me the treatment, immediate and definitive treatment. Three things you need to tell me. Diagnosis, Mansi Singh, absolutely correct. It is tension pneumothorax. So tell me, any of you, why we are saying this to be tension? Why it cannot be a simple pneumothorax? Why it is a tension pneumothorax? Why it is a tension pneumothorax? Although those who are saying hemothorax, it could be hemothorax also, but hemothorax with hypotension, it has to be very, very massive hemothorax. Okay, so although it could be hemothorax also, but the best possible answer here is tension pneumothorax. Yes, tension pneumothorax because there is hypotension. Yes, very good, very nice. Okay, proud of you, very nice. So you are saying tension pneumothorax. So what is the immediate treatment in the tension pneumothorax? Immediate, you will put a needle. Okay, a 14 gauge needle. Where will you put the needle if that patient is adult and if that patient is a child? Adult, where will you put? 4th or 5th intercostal space, mid-axillary line. In kids, 2nd intercostal space, mid-clavicular line. And yes, very good, you are saying definitive treatment is put the ICD. Put the ICD. Put the ICD. Okay, suppose a patient comes with an open wound on the chest wall. There is a 5 centimeter open wound and the patient is having respiratory distress. Now if I ask you that what is the diagnosis, what is the initial treatment and what is the definitive treatment? Tell me for this patient X. Patient X. Second in children, because that is the safe area. More than the safe area, the basic concept is when you are putting the needle, you have to be very, very sure that you are entering in the pleural cavity. It should not happen that your tip of the needle is present in the chest wall and the patient is getting no benefit. Okay, so that's why in kid that area is superficial. So when you put it, there are like highest chances of going into the the pleural cavity. Yes, Mansi, great. Open pneumothorax, very good. This is open pneumothorax. Initial treatment is, yes, you have to put a 3-sided occlusive dressing like this, and definitive treatment is ICD. Okay, it's not packing, Sahil, it is just a occlusive dressing. You don't have to pack it, you don't have to put inside it. It is just a occlusive dressing. Yes. Okay, so this question, immediate management, needle. Put a needle in because the patient is adult, so in the 5th intercostal space, mid axillary line. Okay, so 6th question. 32-year-old female presents with dilated tortuous vein over the lower limb and caliber is 6.6 mm, means it is a varicose with pigmentation involving the area above the ankle. What is CAP grading of the lesion? In the CEAP, that is clinical, etiological, anatomical and pathophysiological, they are asking about the C thing. C. So what should be the answer here? Okay, C4 is correct. Yes, to be more specific, somebody is specific. Yes, Kartika. Okay, C. What is 4? What is C4A? C4A is hyperpigmentation or eczema. C4B is lipodermatosclerosis or atrophy blancae. And C4C is corona phlebitica. Okay, so yes, this is C4. Now you tell me, there is a patient whose name is Mr. Z or Z, Mr. Z. Mr. Z comes and he is having a healed ulcer in the gaiters area. He is a traffic policeman who has to stand for more than 12 hours a day, and his great saphenous vein is having problem, and there is reflux of blood. Now you tell me Mr. Z's CEAP class. Although in the exam you will get easy question, but you tell me all the things in this CEAP. Anybody? If you are saying C5, I am happy. Okay, healed ulcer, C5. C6 is active ulcer. Okay, Noah. C6 is active ulcer. Bhagya, C6 is active ulcer. There is healed ulcer, so it will be C5. Now you tell me, what should I write in E, A and P? E, etiopathogenesis. Traffic policeman stands for more than 12 hours. So this is a primary varicose vein. C is congenital, S is secondary, P is primary. A, superficial system is involved, so AS, superficial. Pathophysiology, reflux, PR. Okay, although in the exam they will ask like this, what I have asked, a very straightforward C. But yes, you should know about the E, A and P also. So this is just a random example to tell you that what is the meaning of this E, A and P also in this case. Okay, suppose it is written C2A and C2S. how this patient A and patient B are different. C2A and C2S. What is the difference between patient A and patient B? Anybody? Yes, very good, Saf. Nice. What is the difference? Yes, Prachi, very good. Patient A is asymptomatic. Varicose vein, but asymptomatic. Patient B is symptomatic. Same, both are having varicose vein only, but one is symptomatic, one is asymptomatic. Very good, very nice. Very nice. Okay, so moving to the next question. All clear? Anybody, any doubt, please, you can ask. A child presents with evisceration of the bowel loop coming out of the defect in the abdominal wall right to the umbilicus. This is a picture. So looking at the picture, this is a congenital defect of the abdominal wall. Yes, it is gastroschisis. It is gastroschisis. What is omphalocele? In omphalocele, there will be a defect, but that defect is at the level of umbilicus, and it will be covered by membrane. In gastroschisis, there is umbilicus is present normally. The defect is present just to the mostly right side, left side can also occur, and you can see the bowel loops coming out like in this picture. Okay, so that is gastroschisis. This is omphalocele. Another picture which can give you a like confusing kind of images, ectopia vesicae. This is also a congenital abdominal wall defect in which the anterior abdominal wall below the umbilicus is absent. Okay, this is absent, and you can see here directly the urinary bladder, and that too posterior wall of urinary bladder. Okay, so the anterior abdominal wall below the umbilicus and the anterior wall of the bladder is absent. You can see directly the posterior wall which is facing the environment. You can see the ureteric opening. You can see the urine dribbling from it. Okay, so that is ectopia vesicae or extrophy of bladder. Extrophy of bladder. Okay, so these questions will be asked image based only, so you have to see and you have to answer accordingly. Okay, clear? So this is gastroschisis. Okay, next question. All of the following are the parts of asepsis wound grading system except. What comes in this sepsis type of wound infection or the wound grading system? It's very good. Anisha, Bhagya, Mansi, Saf, Vinod, Arohi, Talim, very good. All of you absolutely correct. A stands for additional treatment. Okay, whether there is any antibiotic use or there is drainage of pus or debridement, that is A. S stands for serous discharge. E is erythema. P is pus discharge. S is separation of tissue. I stands for isolation of organism or bacteria. And another S is if the stay prolonged for more than 14 days in the hospital. Okay, so this is a sepsis score. Very good. Another important score for this wound infection is, what is the another important score for this wound infection? Southampton score. So you need to remember these two scores. 0 is normal healing. 1 is normal healing with bruising or mild erythema. 2 is erythema and other signs of inflammation. Other signs of inflammation like pain, tenderness, edema. 3 is serosanguinous discharge. Serous discharge or serous mixed with the blood. 4th is pus discharge. And 5th is deep infection. Deep infection that might include separation of tissue, or there can be a deep hematoma which needs aspiration. SIRS, Noah, is not for wound infection. SIRS is for sepsis. Okay, it is for the sepsis or the septic shock. This is for the local wound infection, that whether that wound is healing nicely or there is some infection. These scores are for that. Asepsis and Southampton are for that. Okay, so induration is not a part. I stands for isolation of organism. Okay, next question. A male patient presents to the hospital with abdominal pain and incidentally detected with abdominal aortic aneurysm. What is the appropriate management of this patient? Abdominal aortic aneurysm, they are asking what is the indication for surgery. You tell me 2 indications. And one more thing, you tell me investigation of choice for screening and for diagnosis. Yes, very good. All of you who are saying D as the answer. Yes, D is the correct answer. Indication for surgery is if the diameter is more than 55 mm, or second is if the rate of growth is more than 1 centimeter in 12 months or more than 0.5 centimeter in 6 months. Okay, so you can remember it like you can remember either as centimeter or millimeter, so whatever you feel is correct. Okay, so you can let's remember it in the form of centimeter only. So more than 5.5 centimeter you have to operate. If the growth is more than 1 centimeter in 12 months or more than 0.5 centimeter in 6 months, then also you have to repair because the chances of rupture is high. Investigation of choice for screening is ultrasound and for diagnosis is CECT. Okay, angiography is not a good investigation to monitor the size. Yes, very good, Shweta. Screening is ultrasound and for diagnosis CCT. Okay, so question number 9, the answer is D, monitor till the size reaches 55 millimeter. Next question, in a patient with parathyroid adenoma, how do we confirm the removal of the correct gland after surgery? So one way of confirming is you do the frozen section. But suppose frozen section is not available, how will you know that the thing which you have removed is the correct thing? 50% reduction in the serum PTH within 10 minutes of the gland removal. What is the name of this? This is Miami criteria. Miami criteria. Hyperparathyroidism, parathyroid adenoma, investigation of choice for localization. I mean, you cannot do this question wrong. I mean, you cannot forget this thing. This is such a commonly asked thing. Investigation of choice for localization of the parathyroid. Yes, SESTA-MIB scan. Technetium 99 SESTA-MIB scan. Okay, no mistake should be done in this. Now, parathyroid hyperplasia. What are the treatment options? In adenoma, the treatment is you'll give small incision and remove that thing. SPECT, don't mark SPECT. Okay, Technetium 99 SESTA-MIB you should mark. If they have given in the combination, usually they don't give in the combination. They write very clearly SESTA-MIB. You should also remember SESTA-MIB. Parathyroid hyperplasia, the treatment is either 3.5 removal or all 4 with auto transplant in the brachioradialis muscle of the non-dominant forearm. Okay, so for adenoma, you do the treatment, you will do the removal of the involved gland. For hyperplasia, these are the treatment options. Yes, Salim Khan, very good. Forearm muscle. Next question. Identify the correct points regarding SIRS. SIRS is Systemic Inflammatory Response Syndrome. Systemic Inflammatory Response Syndrome. Okay, so what are the 4 things? You will see this SIRS is 2 or more of the following 4, either 2 or more than 2. So what is these things? Temperature either less than 36 or more than 38. Less than 36 or more than 38. Then what is the next thing? Heart rate more than 90. Then respiratory rate more than 20. Then TLC either less than 4,000, more than 12,000, or more than 10% band form. So in the question, this is correct, this is also correct, this is also correct. It is not less than, it is more than 20. So this is the incorrect option. So 1, 2 and 3 is correct. Okay, I guess the option was removed. Suppose this is A, B, C, D. 1, 2 and 3 are correct. Okay, yes, very good, Karthik. Now here only I want to ask you one more thing. Tell me, what do you see in Q-SOFA score? I want you to tell me what are the things you will see in quick sequential organ failure assessment score. This is also important question. Q-SOFA score. Tell me the things. Okay, I'll write it for you. You just tell me the value. Systolic blood pressure less than 100. What else? Respiratory rate more than 22 and GCS less than 15, that is altered mental status. Very good, Bhagya Lakshmi, very nice. Anisha Das, very nice. Altered mental status. Okay, so you'll give 1 point for each. 1, 1, 1. If the total are 2 or more than 2, it means there is high mortality. Okay, so SIRS and Q-SOFA score. Okay, so next question. Which of the following statement is true regarding retrosternal goiter? Operated only if the patient is symptomatic. Retrosternal goiter, always surgery. Okay, so this is wrong. Retrosternal goiter, this is wrong. Next question. Sternal incision is always required. This is also wrong. Sternal incision is required if it is a primary, or you can say ectopic retrosternal goiter, or if there is secondary, which is extension beyond aortic arc, then only sternal incision is required. Otherwise, majority of the retrosternal goiter can be removed by neck incision is the correct statement. Majority of the goiter derive their blood supply from mediasternal vessel. Majority of the goiters are, retrosternal goiters are secondary. Secondary are more common. And secondary is which is normally placed, it is just extending into the retrosternal area. So that is a normally placed goiter having a normal, superior and inferior thyroid artery blood supply, which is extending into the mediastinum. Okay, so option number D is correct. Rest of the statements are wrong. Okay, many people, they have marked this correct. Okay, so tell me the name of the sign. What is the clinical sign you will see in a retrosternal goiter? What is the name of the sign in which you ask the patient to raise both the limbs above the neck, and you will see that the face becomes, there is flushing, there is dilated vein. What is that name? Yes, very good. Pemberton sign. Pemberton sign. Very nice. Okay, so all are convinced why the answer should be D and why the other three statements are wrong. Okay, all convinced? Yes, now we'll go to the next question. A patient comes with pain, abdomen and jaundice. MRCP is given below. What is the management? Tell me, what does the MRCP image shows? This is the gallbladder. This part is the CBD. This small part may be pancreatic duct. And this black colored thing which you can see here is the CBD stone in the common bile duct, which can come with jaundice and there can be pain abdomen. So if there is a CBD stone, what is the treatment? What is the treatment? Treatment is ERCP and stone removal plus stenting. Okay, so ERCP. After you do this, then you can, then you can go for cholecystectomy. After doing this, the next thing you can do the cholecystectomy, because most of the stones, they come from the gallbladder only. Okay, so yes, this is choledocholithiasis and a very typical CBD stone, and the treatment is ERCP and stone removal followed by cholecystectomy. Okay, it is, yes, both diagnostic as well as therapeutic, but it is mainly a therapeutic modality these days. We don't use ERCP only for the diagnostic purpose. Okay, so remember, ERCP is not used only for the diagnostic purpose these days. It is mainly a therapeutic modality. I'm glad that you have identified the problem based on the image, that it is a CBD stone. Very nice, proud of you all. This is also, I'm sure most of you have marked this correct. Patient comes with a midline swelling of the neck measuring 2 cm. Midline neck swellings are mostly thyroid. To confirm, you ask the patient to swallow, and if the swelling is moving with the deglutition, it is thyroid. On histopathology, it shows following picture. What is the most likely diagnosis? Okay, if I enlarge this picture, you can see there are multiple cells which are empty, hollow, empty cells, which are known as orphan NEI nuclei. Orphan NEI nuclei. So this is a papillary thyroid cancer. It is PTC. What other findings you will see in papillary thyroid cancer apart from orphan NEI nuclei? Anything else you can see? Anything else in the histopathology? Samoma bodies. Yes, very good, Shakila Shah. Samoma bodies are seen. What finding you will see on medullary thyroid cancer? FNAC, special feature of FNAC on medullary thyroid cancer. There will be a myeloid stroma. And now if I ask you, what is the special thing about follicular thyroid cancer on FNAC? This, if you tell me, what is that special peculiar thing about follicular thyroid cancer on FNAC? Anybody please just say what I want to hear. Say that thing. Follicular thyroid cancer FNAC. Yes, very good, Shakila Shah, very good. It cannot diagnose because it cannot differentiate. I mean, it's not, Ayesha, it's not that you don't do FNAC. You'll do FNAC, but FNAC will not differentiate that it is follicular thyroid cancer. Okay, it cannot differentiate between follicular adenoma and follicular carcinoma. That's why if FNAC says follicular cells, then the next thing you can do is you can do a hemithyroidectomy and send that for histopathology so that you can differentiate based on the capsular and vascular invasion. Very nice, very nice. Proud of you all. Very nice. Okay, just tell me one more thing and then we can go to the next question. Medullary thyroid cancer, what are the tumor markers? Anybody? Medullary thyroid cancer, just one thing I'm asking. Tumor marker in medullary thyroid cancer, there are actually 2 tumor markers. So if you tell me the name, I can go to the next question. Yes, very good. Calcitonin, very nice. Another is CEA. Yes, CEA and calcitonin, these are the tumor markers in medullary thyroid cancer. Great. Next question. A paraplegic patient develops ulcer over the back which was full thickness, complete skin loss, going into the subcutaneous tissue but not underlying fascia. It is the complete skin is gone, but it is not involving the muscle or the bone or next thing. What pressure sore is this? Stage 1 is when there is only edema. The skin is fine. Stage 2 is partial thickness skin loss. Stage 3 is full thickness that can go into the subcutaneous tissue but not beyond fascia. Stage 4 is when it goes beyond fascia, which can involve the muscle and the bone. Okay, and there is one stage 5 also, that is unstageable, when on the ulcer there is a scab or eschar type thing present. Then you cannot stage it unless you remove the scab, and you will see how deep it has gone. Okay, Shakila, adjacent structure is nothing. There is nothing like adjacent structure in this. This is not a structure. This is just a skin. How deep we are going, we are looking for that. Okay, it is not an organ that will say the adjacent structure. Okay, so the answer here is they are saying complete skin loss, not involving underlying fascia. It is stage 3. Like you all are saying, it is stage 3. Decubitus ulcer or this bed sore is very important question. Okay, this is the decubitus ulcer or the bed sore. Okay, all clear? How will you prevent this? How will you treat this? Treatment method, you will do the debridement. You can give a negative pressure dressing. Okay, negative pressure wound therapy, in which you will apply the pressure minus 125 millimeter of mercury. Prevention, water or air mattress. Frequent change of position. If the patient is supine and if the patient is on wheelchair, how frequently in supine and how frequently in Ankita, in supine every 2 hours. 2 hours. Wheelchair every, yes, correct Ankita, 10 minutes. 10 minutes, every 10 minutes the patient should just lift himself for a little bit, and if the patient is supine, then every 2 hours the patient position should be changed on the bed. Very nice, great. Next question. After taking a 24-year-old male with a gunshot wound to the abdomen, it is discovered that he has a significant sigmoid colon injury with spillage. He is given Hartmann colostomy and his fascia is closed while the skin is left open. The whole thing about this question is the skin is left open to heal on its own. How will this wound heal? How will this wound heal? Those who are saying secondary intention, full points to them. That is the thing. Primary intention is when the edges are approximated, like sutured wound. So the healing will occur fast and the scar will be thin and neat. How can you do this while sleeping every 10 minutes? You don't have to do this. Okay, people, they say that you have to take deep breathing also. Okay, but you cannot do the deep breathing when you're sleeping. When you're sleeping, you are under control of the God. So if you're under control of the God, you can relax and sleep. Okay, so don't worry about it. Sleeping part. And the people who are on wheelchair, usually they sleep on bed. Okay, I mean, they cannot walk, but they can lie down. So don't worry about this. Okay, they will be sleeping on the bed. And on bed, they can turn themselves. They cannot walk, but they can turn themselves. Okay, champ. If the person is on wheelchair, does not mean that he does not have a bed. He will sleep on the bed. Okay, so primary intention is when the edges are approximated. Secondary intention is when the wound is left open to heal spontaneously. Okay, so this spontaneously, the wound will heal on its own. That is secondary intention. The healing will be delayed and the scar will be very bad and ugly. Tertiary intention is in the delayed primary suturing, in which you will do the suturing after 2 to 6 days. After you make the wound clean, you do the suturing after 48 hours to 6 days. And if there is a skin grafting, so in these cases, the wound will heal by tertiary intention. There is nothing like quaternary intention. There is no name like quaternary. It is just to, given as to confuse you. Nothing as quaternary. Hyperacute rejection in transplant is caused by. Hyperacute rejection is caused by preformed antibodies and also if there is ABO incompatibility. How will you check that if there is preformed antibodies? Preformed antibodies are usually occur because of the prior transplant or the prior blood transfusion. So you check by cross-match assay. Cross-match assay between the potential donor and the recipient. And remember, if it comes out to be positive, it is an absolute contraindication. Absolute contraindication. You cannot do the transplant in that patient. Okay, cross-match assay. But suppose there is ABO incompatibility, there is HLA incompatibility. In those cases, you can very well go ahead and do the transplant. But preformed antibodies, if it is there, it is absolute contraindication. Okay, and if I ask you that what is the most common cause of graft loss? Which type of rejection? It is chronic rejection, which occurs from 6 months to up to years. And if I ask you which type of rejection is reversible, only one is reversible, that is acute rejection. Acute is reversible. Rest, this hyperacute and chronic are irreversible. Hyperacute and chronic are irreversible. You cannot save the graft in these cases. Okay. Next question. I hope all of you have marked this correct. A patient receives a scald bun. Scald means from the hot liquid to his leg after spilling hot tea. The bun is red and blistered and is painful to touch. What is the degree or the depth of bun? Acute is, yes, within first 6 months. Noah, you are correct. Within first 6 months, you are correct, Noah. It is very good. It is second degree. Now, if I ask you second degree superficial or second degree deep, which one? Superficial or deep? Second degree superficial or second degree deep? First degree, so there is nothing. There is just redness. There is erythema. The skin will be intact. Erythema, it will be painful. Second degree superficial, yes, very good. Superficial. This is superficial. In deep, also this blister is not. In superficial, mein blister is very commonly seen, and you can see a very nice blister here. In deep, it is mottled pink or pale. The skin appear mottled pink or pale, not like this blister wala. And in third degree, the skin appears black, hard, leathery, that is eschar. In fourth degree, though, the skin is totally gone. You have gone beyond the skin, maybe in the muscle, maybe in the bone. Okay, yes, correct, Subhash. Third degree is painless. Third degree is painless. Yes, confident about the burn, degrees, depth of burn. Yes, very nice. So, answer here is second degree. Next, the most common arrhythmia seen during laparoscopies. See, in the laparoscopy, when we do the first step, suppose this is the abdominal wall, this is the head end, this is the the foot end of the patient, this is the umbilicus. So what is the first thing we do? We put a needle. Through this needle, we'll give carbon dioxide inside the abdominal cavity. What is the name of the needle? Anybody? Veris needle. So carbon dioxide goes inside. So when carbon dioxide goes inside, there the peritoneum starts stretching. And because of this stretching of peritoneum, sometimes sinus bradycardia can occur, which is the most common arrhythmia. Yes, very nice, Karthik. Very nice. Peritoneal stretching because of CO2 inflation. I'm highly impressed. Okay, so now if I ask you one or two things, what is the ideal intra-abdominal pressure in laparoscopic surgery? What should be the ideal pressure? I guess there is a question on this. I don't know. What is, tell me even if there is a question on this. What is the ideal intra-abdominal pressure during the laparoscopic surgery? 10 to 15 mmHg. You can say on an average, we keep our patients intra-abdominal pressure at 12 millimeter of mercury. The range is 10 to 15. If it is less than 10, you will have less space. If it is more than 15, then the pressure can be too high and it can cause physiological changes. Very nice, 10 to 15. Okay, so sinus bradycardia is the answer here. Which of the following signs is seen in acute cholecystitis? Acute cholecystitis. Which of these signs are seen? Shakila Shah, very nice. I mean, if you're saying A as the answer of question number 20, then it is very nice. If you're saying A as the answer of 19, then no, it is. So A, Murphy's sign. Yes, you are correct. Murphy's sign. What is Murphy's sign? When you do the palpation in the right iliac fossa, when you keep your hand there and ask the patient to take a deep breath, there will be sudden catch in breathing. Yes, very good, Sandeepa Naveen. There is BOA sign also. In acute cholecystitis, there is a BOA sign in which there is hyperesthesia in 9th to 11th rib region. Murphy's sign is this sudden catch in breathing on deep inspiration. So this is acute cholecystitis. Now we'll not end this question here. Tell me, where will you see the Cullen sign and what is Cullen sign? What is Cullen sign? Yes, Karthik, very nice. Cullen sign is seen in acute pancreatitis. Okay, so this is seen in acute pancreatitis. What are these signs? There is discoloration or ecchymosis around the umbilicus. That is Cullen's. If there is the same thing in the flanks, it is Gray Turner. And if the same thing occurs in the thigh or in the groin area, then that is Fox sign. Okay, yes, these are the signs of hemorrhagic type of acute pancreatitis. Okay, so Cullen's, Gray Turner, and Fox. Now, what is Rovsing sign? What is Rovsing sign and where will you see this? Rovsing, and where does it is present? Rovsing is seen in acute appendicitis. It is when you do the, suppose, when you do the palpation in this area, if you palpate, then patient will have pain in this area. That is Rovsing sign. Okay, palpation in the left iliac fossa causes pain in the right iliac fossa. That is Rovsing sign. And like all of you are saying, Patel is correct in the post-auricular or mastoid ecchymosis, which is a feature of skull base fracture. Midcranial fossa. Yes, very nice. Midcranial fossa. Yes, yes. See, looking at your response, I feel so happy, so elated that you guys are doing really well. I'm so proud. I mean, this is like, I'm not saying just for the sake of saying and just because I'm taking class. It is really a great feeling when you see your students are doing so nice. Okay, now it's the matter of the day. You are prepared. Okay, so all of you, I'm sure you will pass with great thing, but great marks. So very nice. Let's discuss the remaining questions. You are well prepared. Very happy. Next question. True regarding direct hernia. Direct hernia. So you just tell me which statement is true or false. Common in children and young adults. True or false? Tell me true or false. Direct hernia is mainly because of the weakness of the abdominal wall and it is seen in elderly people. Elderly. So this is false. Defect is felt below the pubic tubercle medially. Inguinal, okay. Inguinal hernia. The defect is above and medial to pubic tubercle. And femoral hernia. The defect is below and lateral to pubic tubercle. Okay, so they are saying defect is felt below the pubic tubercle. That is again a false statement. Descends through the inguinal canal and goes till the bottom of the scrotum. Okay, it comes directly into the, like this. This is the sac. Okay, so it is not descending through the inguinal canal. It is coming directly into the inguinal canal. It does not come from this side. And it rarely goes up to the bottom of the scrotum. So this is also false. Neck of the sac is medial to inferior epigastric artery. See, this is the inferior epigastric artery. So this is the direct inguinal hernia sac. Indirect hernia sac comes like this. So that is indirect inguinal hernia. So option number D is correct. I'm sure all of you are, you know the basics, what is direct, what is indirect, what are the basic treatment options, the open surgery, what is herniottomy, herniorrhaphy, hernioplasty, laparoscopic surgery, what is TAPP, what is TP, what are triangle of doom, triangle of pain. Okay, I'm sure, you know the things, so you just have to have one reading and you'll remember all the things in the exam. You are doing great in the DFX also. So this is clear. Option number D is the correct answer. Suppose a patient is having both direct as well as indirect. Then what is the name of that hernia? What is the name of that hernia? Starts with P. P hernia. What is the name? Okay, pantaloon. Suppose the question is, what is the treatment of congenital hernia and the treatment of congenital hydrocele. What is the answer? What is the answer? And one more question. Hernia which has maximum risk of strangulation. Yes, you're correct. Herniotomy for both. Whether it is congenital hernia or hydrocele, the treatment is herniotomy. Hernia which has maximum risk of strangulation. And last, hernia with sac contains maximum risk. Yes, femoral hernia. Very good, very nice. Hernia when the sac contains appendix. What is the name of that hernia? When it contains Meckel's. When it contains only a part of circumference of bowel. Yes, Meckel's. Meckel's में what is the name? Litter's hernia. Appendix, ambient hernia. And only a part of the circumference, Richter hernia. Only a part of the circumference, Richter hernia. Yes, very good, champ. Great. Okay, so answer I told you, D. Next question. Causes of distributive shock are all except. Distributive shock. Most common injured nerves in hernia surgery. Noah. Open hernia. Nerves at risk. Ilioinguinal nerve. Iliohypogastric nerve. And genital branch of genitofemoral nerve. Genital branch of genitofemoral nerve. Lap hernia. Nerves at risk. Here, anterior cutaneous nerve of thigh, lateral cutaneous nerve of thigh, femoral nerve, and femoral branch of genitofemoral nerve. Okay, so these are nerves at risk of injury during the laparoscopic hernia surgery, and these are nerves at risk during the open hernia surgery. Okay. Causes of distributive shock are all except. Septic shock, yes. Neurogenic shock, yes. Anaphylactic shock, yes. MI is the reason for cardiogenic shock. And tell me, in the distributive shock, okay, forget about distributive shock. Tell me neurogenic shock, what clinical feature? What about the BP? What about the heart rate? And what about the periphery? What about the periphery? BP, heart rate, periphery in neurogenic shock. I mean, in any kind of shock, the BP has to be low, then only it is shock, it is hypotension. What happens to the heart rate? Bradycardia, yes, very good. And what about the periphery? It is cold or warm? Cold periphery or warm periphery? Periphery. Cold or warm? Yes, warm periphery. Okay, so that is a typical picture. Okay, so only one shock in which Brad is seen, that is neurogenic shock. In septic shock and anaphylactic shock, the BP will be low, periphery will be warm initially, but the heart rate will be high. There will be tachycardia. Okay, Shak Asif, remember it is warm periphery. Those Shweta Singh, how can it be cold in the neurogenic shock? There is vasodilatation. So because of vasodilatation, the blood pools in periphery. So if the blood is present in the periphery, when you touch the periphery, it will be, blood is not cold, blood is warm. I mean, we are talking about humans. So it will be warm periphery because the blood is present in that area. Okay, Shweta and somebody else also, they said cold. It has to be warm. Okay, because the pooling of blood is in the periphery. In case of like cardiogenic shock, in case of hemorrhagic shock, it will be cold. In hemorrhagic shock and all, it will be cold. But in this case, it will be warm. In the distributive shock, it will be warm. In the other types of shock, it will be cold periphery. Okay. This is a question about true and false kind of question. Okay, so the next question is also true and false type, and then there is arrangement. 3 questions left. So the features of MEN syndrome are, here only we'll see. Pheochromocytoma is seen in MEN1 syndrome. True or false? You just tell me. Option number A, true or false. Pheochromocytoma is seen in MEN2, not in MEN1. So this is false. Prophylactic thyroidectomy is indicated in MEN2 syndrome. Yes, it is true because there are 100% risk of medullary thyroid cancer. So we will do prophylactic thyroidectomy in MEN2. In 2A, it is done at 5 years of age. In MEN2B, between 6 to 9 months, within 1 year basically. Red gene mutation is seen in MEN2 syndrome. That is true statement. MEN1 is autosomal recessive. This is false. All the types of men are autosomal dominant. So what is the correct thing? A false, B true, C true, D false. Okay, option number C is correct. Option number C is correct. Okay, no confusion. All clear? Okay. With respect to the primary skin tumors, which of the following statements are true or false? Okay, they have forgot to write the thing. I'll write it for you. A, B, C, and D. I don't know. I mean, this is in my PPT or in your exam also. It was like that. Let's see. Squamous cell carcinoma of skin is the most common primary skin tumor. Option number A. I mean, this statement A, true or false? It is false. The most common is basal cell carcinoma. Basal cell and squamous cell are low grade malignancy. Yes, true. They are low grade. Melanoma is high grade. Lentigo maligna is most common type. It is false. Lentigo maligna is not the most common. Most common type is superficial spreading type. Lentigo maligna is least malignant type. Nodular is most malignant. That is true. Okay, so again, false, true, which statement? False, true, option number B. Option number B. Okay, last question. Arrange the following clinical features in order of their appearance in chronic arterial occlusion or the peripheral vascular disease, which is mainly because of atherosclerosis or bulges. So initially the patient is asymptomatic. Then there is intermittent claudication. Then rest pain. And pre-gangrene in which ischemic ulcers are seen. And finally there will be gangrene. Okay, so 3 should come at the first. Okay, option number A, 3, then 5, then 2, then 4. Yes, this option number A is correct. Option number A is correct. Okay, so thank you very much. You are doing very great, and I'm so happy, so proud to see you all are doing absolutely fabulous. And I'm sure you will get in surgery. Suppose there are 45 questions, I'm pretty sure you will make 40 plus correct in the surgery part. Okay, yes, you will get the, I guess they will share. I mean, I don't know whether they are sharing it or not. Even if they are not sharing, I'll share on that group. Okay, so don't worry. Okay, I'll share on that group. Okay, so thank you very much. Good night, and let's see if there is any other session. We'll come across with new questions. You have to practice the MCQs. You know the things, and you just have to apply that knowledge in the MCQs. Okay, so I'll end the session, and you just let me know. Let me know by tomorrow if they are not sharing this PDF. I'll share on that group which I have created on the Telegram. Okay, that group is there. TAMS surgery FMG December 23. On that group I'll share. Okay, so thank you very much. God bless you all, and we'll keep on interacting on that group also.